I just think it was way easier being a doctor back then.
Yeah.
Like now I've got to know all these different things and all these different medications. And back then you're just kind of like, I think you have ghost. Here's some cocaine.
Ghosts?
Yeah.
Yeah.
You know what I mean?
And you just basically
Everyone was possessed.
It was basically cocaine.
It was just cocaine. Everyone was possessed. You gave them cocaine. They felt better.
Or you probably put
I'm
them
pretty
down.
sure. I may have read the history wrong, but I'm pretty sure that's how it was.
I get it.
Yeah.
I get it.
So,
Well, hey, everybody. Welcome to the Sex and Sirens Back to Basic podcast, a podcast where my brother, Christopher Seitz, an ER physician, and I, Jason Seitz, a nurse and firefighter paramedic. Oh, that's the first time I ever led with nurse.
ooh,
I don't like that.
ooh, you want to start
Firefighter,
over?
paramedic, and also a nurse.
Yeah, just on the side.
And we usually take complicated medical topics, break them down back to the basics, make them easy for you guys to digest. Today, we're doing things a little bit different. As we warned you about a month ago, today we are doing our Q&A, our Ask Us Anything podcast. So we have asked you guys to send us in some questions. We've got lots of questions. We're going to try to get through a bunch, and we're going to just kind of talk and answer your questions. We're going to try to do this once a quarter?
Like
Yeah,
every
once a
couple
quarter or so. So keep sending in those questions. Right now, the email to send those into is training@sightsandsirens.com.
Yes.
Send the questions. That might change soon.
Maybe.
Little teaser. Excitement.
To be determined.
About to happen.
To
All
be
right.
determined? I mean, no, I guess it's been determined. It's
To
just
be-
to be announced. To be continued. I don't know.
What are you looking for? All right, so we're just going to jump right in. First question. This person asked if, he said, wanted to thank you guys for your podcast. I was told about the podcast a couple days ago. I just got through a couple episodes. You put on a very entertaining podcast. Normally, most medical podcasts are hard to pay attention to because they're dry and monotone. I agree. He said on one of your episodes, being the PE episode,
Okay.
I believe this was episode 2 for us, I wanted to bring my experience with a patient that had similar behavior as an example in the episode. Another tool, this is from Dave W, by the way. I won't give last names unless you guys ask me to. I wanted to bring my experience with a patient with similar behavior. Another tool in our toolbox would be ETCO2, which would give us real-time reading on efficacy of patients, ventilation, and respiratory efforts because, as you mentioned, SpO2 can have up to a 2-minute lag before it changes. But someone who has a normal SpO2 experience in PE would be having that gas exchange, so ETCO2 below 35 could lean towards possible PE. And he's kind of talking about using ETCO2 as another monitoring device during this during this episode. So for those of you who haven't listened to the episode, what happened was there was a call where the person did not present with any real signs of respiratory distress. She was tripoding, but it almost very much looked like a panic attack. SpO2 was 100%, and no chest pain or back pain. And it turned out that this woman developed a PE. It was a very harrowing call for me. Changed my outlook on the field quite a bit. But she had ended up having a PE, and it was like, oh my gosh. So what Dave's saying is, hey, you could have used ETCO2 to help you out there. Where were you then, Dave? I don't know what to tell you. No, I'm just kidding. So I did answer this question to him personally, too. I shot an email over to him. But one of the things with this is, yes, 1,000%, Chris and I are firm believers in using end-tidal CO2 or capnography anytime you have a complaint that can even possibly be respiratory. You want to talk a little bit about that?
Yeah,
it
so
paints
that's
such a bigger picture, and people just really do not take ETCO2 seriously. I
right.
feel
Yeah.
like. They just don't.
End-tidal CO2 has been around for a super long time, and it supposedly should have been adopted kind of throughout EMS and emergency. But it just isn't. Like we just don't use it as much.
It's the other vital sign.
Right,
Like,
it's like-
people don't.
We still, as much as it should be used all the time. So things we do use it for, I think that we're getting better at using it for, is in cardiac arrest. So end-tidal CO2 can help you essentially evaluate how well your chest compressions are. If you're giving adequate circulation with chest compressions, and if you get ROSC. End-tidal CO2 with intubation, that's the other big one that we know about, that, if the end-tidal CO2 jumps up when we bag the patient after we put an endotracheal tube down, okay, we've got the tube in the right place.
Yeah.
But again, like you had kind of mentioned, so we argue that you should be using end-tidal CO2 with any of your respiratory patients. And there's a couple different reasons I'll just go over quickly. One is that it's real time. So you're measuring ventilation with end-tidal CO2. The pulse ox measures oxygenation, kind of, right? And we talk about that in some of our lectures, but basically the oxygenation of the tissues is what we assume the SpO2 is showing us, and that can lag, right? That basically only gives us one number as well. Like there is a respiratory waveform that you hear people say, it wasn't really a good waveform, so I don't think they're necessarily hypoxic and that sort of thing.
It's a pleth wave.
Right. But end-tidal CO2 doesn't lag. So end-tidal CO2 is ventilation. So if you stop breathing, you don't get a reading anymore. And you can actually essentially read the end-tidal CO2 waveform to help you see if there's obstruction, to help you see if there's hyperventilation, hypoventilation, if they're retaining CO2. We're not going to get into it right now, but yeah, absolutely. I think end-tidal CO2 is a
great
huge
tool.
thing, a great tool. In this case, may have helped. I'm not
so in
too
this
convinced.
case, probably not personally, I believe, because I would have recognized the hyperventilation 100%, but I knew she was hyperventilating. The issue was she was, it wasn't going to tell me that there was this obstructive shock going on, that there's this PE happening, right? There's not going to tell me about an obstruction. It would have probably legitimized, I probably would have seen an increased speed of respirations and there a drop in CO2 because that would show that she's hyperventilating.
And that not necessarily wouldn't show you an obstruction, because if you have obstructive airway diseases like COPD or asthma,
sure,
the end-tidal CO2 waveform, but it's not going to show you
obstruction in the lungs,
obstruction.
like a pulmonary embolism.
Airway obstruction, because end-tidal CO2 is measuring ventilation. If you have an airway obstruction, like with asthma, COPD, yes, you're going to see changes in the waveform. This is a good chance for us to plug our National Registry Prep program. So we have an entire lecture on end-tidal CO2, how to read these things. So again, if you're studying for the National Registry, check out our program. It's going to help you quite a bit. But yeah, I mean, for the sake of answering the question today, absolutely, we should be using end-tidal CO2, I think, for any respiratory complaint.
Any respiratory complaint.
In this case, I don't know if it would help or not.
And the thing is, about end-tidal, like it's I think we don't tend to like it because it's not like a true diagnostic tool to us, because we can't be like, this means, it's like an EKG, like this means he's having a heart attack, so I'm going to do this sort of thing. It's really just a diagnostic tool for down the line and for watching trends and things that are a little bit more long term. So I think it's helpful if we come and we have a capnography waveform to give you.
Yeah, absolutely.
That just kind of helps legitimize our report and give you a little bit more of a set point of what's going on. It's just like any other vital sign, right? It gives us a good set point.
Well, and I would argue even the EKG is that way. So I just guest starred on the EMS 2020 podcast, and we were looking at an EKG that, again, one of my arguments for this EKG, which in the beginning people were trying to say, Monday morning quarterback, like, oh yeah, if you see here, it did show signs of ischemia. It's like, well, I don't know if it really did or not, but over the course of time, as they continued to repeat EKGs, they saw changes, and that was important. So again, all of these things are pieces to the puzzle. So the more, tools and things that you can use that are going to be quick, non-invasive, they're going to just add more data to your, diagnostic ability. So.
And this is what I love about the EMS field is like, again, we're not Monday. I don't feel like he's Monday morning quarterbacking me. You know what I mean? But like, it's great to like be able to have discussion with people like outside of my department and outside of like to just be like, hey, like, what about this? Like, could we, if I were with you, you know what I mean? Like, I feel like Dave was in the ambulance with me now. Right? If I were with you, like, maybe we would have shot for the CO2 thing. Maybe I would have been a little bit more suspect towards this. And that's why, bouncing this stuff off and engaging in your education is so important.
Yeah,
so
definitely.
Thank you, Dave, for that question. I didn't do anything wrong. No, he actually sent in another question. I want to cover it right away. Still regarding that call, he said, more just regarding pulmonary embolisms in general. He said the use of heparin. He goes, he has had heparin in our formulary protocol for STEMIs, and he's wondering if the administration of heparin would give more time in a PE so that TPA or interventional radiology could be used. So remember, a PE, guys, is a blockage, a embolus, so it could be air, it could be a fat globule, it could be a thrombus, but it's blocked the vessels in the lungs and it's cut off oxygen supply to our lungs themselves, so they can't, that tissue can't perfuse and your lungs will stop working, like you'll have necrosis, similar to what you have like in a heart attack when you have blockage in a vessel. So what he's wondering is if we give this blood thinner, kind of like we do in STEMI, or when someone's having a heart attack, we give aspirin as an antiplatelet to kind of ease flow. If we give heparin, would it give us more time, you think, to get to that PE? So I'll let you answer that one.
So theoretically, yes. And I'm surprised that it's still in his formulary, because I think what we've found. So we don't do this as much anymore. When I was in training, we would start someone on heparin who had a pulmonary embolism, or start someone on heparin who had an NSTEMI or a STEMI or something like that needed to go. Yeah. We don't even do that much anymore, even for STEMIs and stuff now. So it's really not heparin. We're kind of going more toward these not clot busting drugs, but they just work a little bit differently. So heparin is not something that is going to relieve a pulmonary embolism or make the clot, disappear or disintegrate. All heparin does, based on its mechanism, is it thins the blood out so that there's not more clot forming where the clot currently is. So the idea is if I'm 98% blocked and I have symptoms,
saving that 2%.
Yeah, heparin's kind of hopefully preventing the other 2% to start to get blocked. It's not going to bring it down to 95, 90, 85, anything like that.
Well, one thing that we talk about with, like, when we go over heart attack and stuff like that, even with the use of aspirin, like, it's not even why aspirin and heparin and blood thinners and antiplatelets and stuff are useful isn't just because of that clot area. If I can ease the flow in the other vessels that feed that area, like I'm preventing further. So if my heart's already under stress or that area is already under stress, and you start having blockage of flow and stuff like that, you're at risk for developing more clots and additional to that clot, but also additional clots from that clot. So I think giving heparin, giving antiplatelets like aspirin, that eases the flow everywhere else, just so that you're making sure that you're not making the problem worse, right? So we kind of contain the problem from making it worse, but it doesn't actually solve the problem.
Yeah, and the thing is with now, especially with pulmonary embolism, we use alteplase or TPAs. We're kind of trying to get away from the term TPA and use alteplase because that's the actual medication. But those actually break the clot down. So we really kind of moved away from using heparin, even in heart attack situations, only because there are other medications that I think do a better job that work a little more acutely, and heparin has its own issues with once I've started someone on heparin, well, then they can't have certain procedures and they can have other ones. Right. So
you've thinned the blood everywhere, and you've got to deal with that.
Yeah, mechanism. Yeah. So you're not wrong to say heparin could potentially, but I think we're moving away from heparin being an acute medication that we give. Now that we have some of these other like well vetted, well researched clot busting drugs and in other things like Brilinta is another one that we'll give in with heart attacks and things like this. So again, yeah, I mean theoretically I think heparin would help maybe potentially stop things from continuing to get worse, but it's going to be more of a longer term strategy. I think in the acute setting it's probably not going to really do you much good.
Yeah, cool. All right, why don't you jump on one of these questions starting here?
Here's one. I have trouble telling the difference between you guys when listening to the podcast.
I mean, I think I have a much deeper, richer voice.
I mean, that's not true.
But,
no.
I mean, do you want to do a little duet so people can really understand the difference?
Yeah. No, this is actually funny because we don't think we have similar voices, but
in my mind, I sound completely different than you. In my mind, I sound a lot like Grover.
Really?
Yeah.
Oh. In my mind, you sound a lot like the teacher from, what is it, Peanuts? Just kidding. No, so we have heard this before. I mean, I'm sorry, we can't do anything about it. I'm going to change my voice. But this is actually funny. I'll just quickly share the story. Do you remember?
The rest of the podcast, I'm just like, okay, Chris, we're working.
No, but I don't know if you remember this. So I was in college, and my girlfriend at the time had called me and said, "Hey, can we hang out?" And I was like, you know what? I'm up at Wayne State in Detroit, and she was at a different college at the time. And I said, you know what? I can't today. I got a lot of studying to do, that sort of thing. So later she tries to call me, but she accidentally calls my parents' house, and Jason answers. And again, like this is do you remember this? Story, so Jason answers, and apparently we sound a lot alike. She thinks it's me, and she's like, "Oh, what are you up to?" And he's like, "I'm just playing video games, like hanging out." And he's like, "Oh, wow, I don't know why she's checking. I don't know why my older brother's girlfriend's checking up on to see what I'm up to, but yeah, I'm playing video games." And she's like, "Are you serious right now?"
And then she hung up real quick, and I remember calling you and being like, "Hey, so your girlfriend thinks you're
playing, right? Yeah,
and that you're playing video games."
And she was quite embarrassed. But yes, apparently we do sound alike. I apologize. There's nothing we can do about it. But thanks for the feedback. Just kidding.
That came from Kendra.
All right. Sounds good. Cool.
All right. Let's see. Garrett G asked specifically what my education path was like because of medic to RN bridge and wanted information on that. Now, we shot a preview of this episode where we were like trying to do this, and I like talked for like an hour and a half about my education. So we're going to stay away from that. But he wants to know what both of our education paths were like. He recommended a Q&A podcast like this, so we're taking your advice, Garrett. And then he also says, "Or simply a podcast to talk about yourselves would be awesome." So we're going to ask some quick questions to each other to paint the picture. First of all, my education path, I took an RN bridge program called Excelsior. It's online. I would challenge tests. And then I'd study for like months. They'd send me textbooks. I'd study on my own. And then I'd go into like a Pearson VUE Center, similar to when you take a national registry, and I would take adaptive tests to test for credit. I was able to do that and leverage my clinical experience as a paramedic, because you have to have years of experience. I was able to do that. And then you have a very challenging and aggressive clinical exam at the end where you're with real patients and you fly out and you do like this whole deal. Mine was a little bit different because COVID kind of interrupted it, so I had some online stuff too. But you basically have like a practical national registry that these guys would be similar to, you know, in their paramedic that you got to do. But then you also got to go in and for like a full day, 2 days really, be with patients, and you're just constantly tested on like following the right steps and treating any type of thing that they could have. So pretty scary. That test right there has a 60% attrition rate, which is kind of spooky. That was one of my big turnoffs to the program. I was like, whoa, like even if I get through all of it and I pass the program, this final test is 60%, then I have the NCLEX. Like that sucks. But if I can do it, I know you guys can. And there's resources out there to help. And you guys can always contact us too. That test is called the CPNE, and it's specific to Excelsior College. But if you guys ever want advice on that, we do specialize in test prep. This is kind of what we do. So let us know and we'll help you out. But yeah, would I recommend it? It depends. I mean, if you're the type of person who can self-study and you can challenge tests like that, I would say that I'm not a test taker and I was able to do it. So it just really depends on if you have do you need to have a teacher in front of you kind of encouraging you and pushing you constantly? Are you the type of person that can get up and study, you know, whether you got someone cracking the whip or not? So if you think you can do that, I'm happy to talk to you guys more about it. You guys can send us messages and emails to Sights and Sirens, and we'll walk you through it. But that was my education path. What was your education path like? Well, beyond that, like I am a firefighter paramedic. That's right. Yeah, so like I went to the academy. I did the normal thing. So a lot of people can do this in different orders, but I did EMT, and then I did the academy, and then I did paramedic, and then I worked paid on call for a while, and then full time since, and have just about a decade of experience in the fire service now.
Cool.
So what about you?
So I got a bachelor's degree in biological sciences.
Boring.
Right. So it's a BS degree in BS. I think that's what my diploma says.
It's a bachelor's of science.
Yeah, a bachelor's of science in biological sciences. So then I went to medical school. BS. So then I went to medical school.
Because where else would you go with
right,
that?
You're right, exactly. So I went to medical school for 4 years, and then
if you guys could see, if you guys are watching on the video cast right now, the look of just
despair
in his eyes.
Sorry. I'll perk up.
And then I went to medical school.
All right, I'll perk up. So I got a bachelor's degree. It was great. Then I went to medical school.
It was a lot of fun.
Yeah. And then from there I went to residency. So I did an emergency medicine residency, which was 3 years. And then I got board certified in emergency medicine. And I've been working as an ER physician. So actually the first 2 years I worked under, like I said, a hospital contract for a couple of years in the Detroit area. And then I started doing travel medicine. So I've been doing travel medicine for the last 3.5, 4 years. I've got like 15 state licenses, and I fly to different parts of the country and help in ERs that need the help and that sort of thing, which has been
Which I think is giving you like he's given him a wealth of experience because he's been in a ton of different ERs compared to most docs.
Yeah.
And he's traveled all different areas in the country, which is really helpful, I think.
Yeah.
And
it's cool because like a lot of the stuff stays the same. Like diabetes in North Carolina is the same as diabetes in Michigan.
It's not different. Yeah, that's weird.
You know, but then like the system part of it can be very different, or resources. That's the one thing I run into a lot is like, I'm like, oh my gosh, this baby's coming. Call OB. And they're like, we don't have OB. And I was like,
we're in Hickville.
Right. So then it's
Here's
me.
pliers.
So yeah, right. so that's kind of cool. But I'm actually looking at maybe transitioning away from some clinical,
into a woman.
No, not that kind of transition.
Not that kind of transition. Oh, I'm sorry.
Oh, okay, yeah,
because we have talked before.
No, we didn't. So I'm going to transition from doing a little less clinical and start doing some more of our educational stuff too. So
well, that's the other thing is that most of our time, I think, if we're not at work, it's taken up doing stuff like this. Mm-hmm. So we run this podcast, and we also run our National Registry test prep program, which helps people through school for EMT and paramedic and advanced EMT. And we deal with a lot of students. We film fun educational videos. We also work on AHA training center stuff on the side. But this is we stay busy.
Mm-hmm.
All right, personal life, go. What makes you you? No, tell me about your family and tell me about your hobbies. Go.
Okay, so I am married and I have 3 kids. I have a 7-year-old boy and 2 twin girls. So obviously I'm just busy all the time.
And they are identical twins.
They're identical twins, yeah. They're blonde-haired, blue-eyed identical twin girls. So it's just horrible. Like they're 5, and I needed to stop there.
Yeah.
Or I'm gonna have to lock them in a basement for 18 more years.
Jeez.
So anyway, but yeah, so I do that. Hobbies. I don't know. I like to I travel a lot. My wife and I like to travel. I like doing more physical sports stuff too. So haven't been out in a while, but like I said, scuba diving and mountain biking, hiking, and that sort of thing. What I enjoy.
Cool.
And I started picking up golf because I'm a doctor, and apparently that's what everybody else does, and I can't have friends unless I golf, and I'm really bad at it.
I'm really embarrassed that I don't really know anything about golf. Like I don't even know like golf lingo. Right. And I feel like people will be like, oh, yeah, you like, they know I like outdoor stuff. They're like, oh, you like golf, right? And I'll be like, I'm like, putt-putt, yeah.
Yeah, exactly. Right. You putt-putt. But yeah, no, so I picked up golf. And when I say I picked it up, I mean I picked it up in the last like 3 weeks, and it's not going well. So that's...
I'll probably be dropping it soon.
I'll probably be quitting that soon. So,
oh, cool.
Yeah. What about you?
I'm married, and 3 days ago I bought a cat. So just super depressed.
Things are going great.
We did just get a cat. His name's Hobbs. Mm-hmm. He's really cool.
That's great.
He's 10 months old. He looks like a tiger, so we named him Hobbs.
Cool.
Calvin and Hobbs.
Yep.
I don't know. That's kind of a big part of my life right now.
Okay. All right.
I didn't want it to be. I wanted to get this cat not to be a big deal, but I'll be honest with you, it's kind of a big deal. It's been kind of fun. I spent $200 on this like wall system that he can climb on. It has a suspension.
Are you serious?
It has a suspension bridge. I gotta show it to you. It's crazy. But anyway, so I'm kind of like, I might need a
things have gone rapidly downhill for you. Okay,
an intervention. Right. No, but no, I've been married to my wife we're coming up on 7 years. Yeah, I don't know.
Hobbies.
I'm a big mountain biker. So we actually just moved recently, very close to a metro park in my area that has trails that I love. So like we spend a lot of time in that park. We do like kayaking there, fishing. We don't catch anything. It's just sort of like we cast out and then just sit there. But like it's mostly just being in the kayak. Okay. But I mountain bike probably 4 or 5 times a week. I love mountain biking. I'm a big scuba diver. I'm a dive master. So when I can rope Chris in to come with me, we go out and scuba dive because you need a partner or you can die.
True.
And that's really the only reason why I dive with him.
Check out episode, I don't know, was it like
episode 3, I believe, was our diving emergency podcast. We talk a little bit about that. I'm a big board gamer. I have over... now you don't want to share the... I'm kind of a sad person. I have about...
You're like, I play board games and I have a cat.
Games. So like these board games, though, that I play, they're not like... I'm not playing Monopoly, people.
Are you trying
I'm not playing Scrabble.
No, really
what I'm saying
board
is...
games?
It's probably worse than you think it is. Like, it's not even like I'm entertained with Yahtzee.
Okay, here's the big question then. Do you paint the little figurines and...
If the game requires painting the figurines.
Okay.
No, not really. No, I had done it in the past. I really have not done that. I don't play any tabletop games like that where you like, it's a war. I'd love to. If there's someone out there who wants to get into it, I would. I'm like a hardcore nerd when it comes to games. I love like tactical and strategy board games. Like my wife and I play them. My buddies come over, we play them. We have game nights. I built my own gaming table. I have a life-size Batman in my basement. I'm big into comic books.
That's true. He does.
I'm like very nerdy.
Yeah. Cool.
But you know what? I'm not ashamed.
That's good.
I am ashamed that I'm so into my cat though.
Fair enough.
Because I got weird. That's when things I feel like tipped over too.
3 days ago when you got a cat.
Like it was fine for you to have a life-size Batman in your basement, like a life-size statue of Batman. That's fine.
Right.
But you bought a climbing system for your cat with a suspension bridge. I might need some help.
Yeah. All right. I'll keep that in mind.
We'll talk after this. Anyway, next question. Okay, so here's a great one. This comes from Stephen R. And he says, I keep getting easy questions wrong on tests because I use CAB, or circulation airway breathing, versus ABC, airway breathing circulation, in the assessment. How do I know when to use which? I thought it was always CAB now.
Okay. We actually have gotten this question a couple different times, so I'm going to quickly blow through it right now. So it is always, if you want to, like the blanket statement, is we got kind of confused when the American Heart Association, some of these organizations went to CAB, which is circulation airway breathing.
It was basically you're just checking a pulse before you would check airway and breathing.
Well,
kind of. I mean, that's what people thought it was.
Became. Yeah. So it's more it's always airway breathing circulation. It is always ABC. The times that it's not going to be ABC, cardiac arrest. Okay? So in cardiac arrest, you're going to go right to circulation. And that doesn't really necessarily mean checking for a pulse. It just means doing chest compressions. right? Like,
yeah, but you
that's
won't
kind
know
of,
that they have. That's what confuses me because you don't know. So what I usually say is, if your patient is unresponsive, you can shift to and you suspect cardiac arrest, you can shift to a CAB.
Yeah, CAB.
But the thing is, like, I think the real question here is on test questions, because like in the field, like we know we're going to check airway, we're going to check breathing, we're going to check circulation. That all kind of happens at once anyway, right? If I'm coming up to you, I can see if your airway is patent.
Right.
If you're talking to me, I know you're breathing, I know you have a pulse. Like if you're unresponsive, I might hear snoring respirations as I'm approaching or whatever. Right? And I'm going to kind of check a pulse, look at your airway, do all that at once.
Right.
So like this isn't a problem in the field. Like we don't get like people are like, I've lost so many patients because I went with ABC.
Right.
It doesn't happen.
Right.
But in test questions, CAB will only be when they're talking about
cardiac arrest or unresponsive.
Cardiac arrest, CPR, and it's like a obvious AHA type question.
Right.
Yeah.
Yeah.
Like that is, in my experience, I've never seen outside of there. Like always go with ABC. Nursing is all ABCs, all of that stuff, until they ask you a very specific cardiac arrest question that you can tell, like, this is a BLS question.
Right.
This is a basic life support question. It's asking me about CPR. Okay, in that case, I'm going to lead with checking for a pulse first.
Yeah.
Because the idea there is just to save time and to concentrate on compressions being the most important thing.
Right.
They're trying to get you to realize that it only matters if they have a pulse right now, because if they don't have a pulse, we know that they're not breathing. We don't have to worry about
and that's the
Jump
other
right on the chest.
That's the thing too, is that people were getting a little confused, because even in cardiac arrest, when patient didn't have a pulse, they might have some like agonal breathing, and then people got confused, and all that did was delay chest compressions, right? So CAB for that. The only other time we're going to use CAB, and we hear this all the time too, is in trauma, but not just trauma as a blanket statement. Like if you fall off a ladder and you break your leg, I don't go to CAB. All right, I'm still doing ABC. When I'm doing CAB in trauma is if a patient appears to be exsanguinating,
a life-threatening
massive hemorrhage. So they've got blood spewing from, like, splurting from their leg. Yes, put compression, tourniquet that, and then move on to the airway and the rest of the stuff.
That's a good point.
But that's the only time. So people get really confused because CAB
they're like, well,
in
he's
trauma,
bleeding though. Like if I write a question, guys, and I write the question and it's like, Nancy, fell off a ladder, clutched her chest, fell off a ladder, is now bleeding, and what do you assess first? It's still gonna be airway. I didn't make that sound like a CPR,
right?
And I didn't make it sound like a life-threatening bleed. Now, if I say, as you approach, you see blood spurting from her jugular. Right,
like,
or whatever. You know what I mean? Like now it's
She's
like, okay,
gone.
well, I gotta get
Nancy's gone.
We're not triaging. No, so yeah, then it's going to be put direct pressure on that wound, and then go ahead and move down.
So
to
again,
assessment.
so cardiac arrest, CAB, and then life-threatening massive hemorrhage, exsanguination in trauma, CAB. Everything else is still ABC. So for the test purposes,
9 times out of 10 on your test, it will be ABC.
Yeah, cool. All right. This question looks like it's for me. It says, "What is your workout routine? You look amazing." So Angela, that's a really great question.
Let's see. Okay, so this question comes from everyone ever all the time.
Okay.
And it is, my test shot off at such and such a number of questions.
Okay.
Did I pass or did I fail?
Sure.
All right, we're going to address this. We have a video on this. Can we put a link to the video?
Yeah, we'll do this. Yeah.
Link to the video on our NREMT stuff. All right. So on adaptive testing, adaptive testing works differently than normal testing. All right. There's 2 types of tests.
And this is this is the National Registry exam.
Well, really, like the NCLEX is adaptive.
Right.
I think MCATs are adaptive. Like any medical test now is adaptive.
Yeah.
It's really frustrating because they're not fun to take. Like, do not think for a second that we are like fans of this test.
No.
We prepare you for it. We don't love taking them. All right. So you have 2 types of tests that you're familiar with. Linear testing, that's what you've always done. Now there's adaptive testing. Linear testing is, let's say there's 100 questions. A set amount of questions, there's 100 questions. You need a certain amount, right? If you get 70 right, you got 70%, that's passing. We label what passing is. Maybe it's 95, whatever. But your brain then triggers when you're taking these tests to think, I'm getting questions right, I must be doing good.
Right.
Okay? Adaptive testing is quite literally the opposite.
Mm-hmm.
Adaptive testing has levels of questions. Let's say there's levels 1 through 10. It might start you off at its baseline. Let's say it needs you to pass it needs you to be hitting level 5 questions. It'll ask you a level 6 question.
Right off the bat.
If you get it wrong, it'll ask you a level 5 question. If you get it right, it'll ask you a level 6 question. If you get that wrong, level 5. If you get that wrong, maybe another level 5. If you get that wrong, maybe another level 5. You have not failed the test yet. You're still answering questions at the level 5 thing.
Right.
So
you've
how
gotten
these
3
are
of the 4 questions
right.
wrong, but you have not. Yeah,
right.
exactly.
And what happens is how it works out, and the National Registry has said this, and I can show you the video where they say it out loud. 99% of people who take an adaptive test will get 50% of it wrong. It doesn't matter how smart you are. It doesn't matter how well you did. You'll get 50% of the questions wrong because they might ask you, because you're a doc, they might be asking you level 10 questions the entire time, and you're jumping from 9 to 8 to 7 and then back up to 8 to 9 to 10. And you're just kind of jumping back and forth, back and forth, back and forth. But you've been above that passing line the entire time.
So if you look at it this way, let's say level 5 is passing. They ask me a level 10 question, and I get it wrong. And then they ask me at level 9, I get it wrong. And then at 8, and I get it wrong. Then at 7, I get it wrong. Then I get a level 6 right, and it goes back up to 7. And I get that one right, and it goes back to 8. And then I get it wrong. I've gotten, like I said, 8 questions wrong and 2 right, but I'm still 2 points above what that quote-unquote passing level is. So if you walk out of your exam feeling like you failed it, that's
fine.
You should,
because you're used
normal.
to 50% being a failing grade,
right?
So and that's the problem is our brain tricks us in these adaptive tests where there's been adaptive tests. So for my nursing program, every test I took was adaptive. It was a horrible way to have to.
Every time Jason took a test for his exam, he'd call me and say, I failed it. I didn't know a single question. And then 3 hours later, you'd be like, I don't know.
When I finished my NCLEX, I told Chris, not only did I not understand what the question was asking, I didn't understand any of the answers, what the words were on the answers. Still passed it. It doesn't. Right. I'm telling you, it's very challenging. In the moment, in the test, one of the best pieces of advice I can give you is just to realize that fact that you're getting a ton wrong, and that's fine. You could be passing because they're asking you super hard questions.
Right.
So just keep working at it. Keep your head up. Keep plugging through.
I would almost argue as a psychological thing. Yeah. If you're getting them wrong, get excited. Just decide that must be that they're asking you super high level questions, which means that you're doing really well. Yeah. Because if you do that, then it's just every question is its own thing, and getting it wrong might be a good thing, and then you don't, because that's what happens is people psych themselves out.
So that being said, then rumors start getting spread. There is a set amount of questions that they'll ask you. There's a minimum amount that you have to be asked. And there's also a maximum amount that you can be asked in an adaptive test. And a lot of people learn those numbers. I think in the National Registry paramedic right now, I think it's somewhere around 120-ish is the max you can get, and somewhere around 75-ish is the minimum you can get. So when people finish and it shuts off at 75, they go, oh, what that must have told me is that I did really well because I passed in the minimum amount of questions. Well, that's not necessarily true. That means you could have done horrible. It might mean they asked you a bunch of questions, you were below the passing line. It's it doesn't matter if we give him 60 more questions.
Right.
He ain't going to cut it. Right. So we're not going to give him any more questions. Or it could mean that you aced it. It might ask you somewhere in between. It might ask you the maximum amount of questions even though you were passing at the minimum amount of question because it wants to add more research to vet these questions for the next test taker. There's also a number of questions in the test that will just be garbage questions that you won't actually be graded on, that they're testing to see if they can put it into their test banks at some point.
Right.
So there's a lot of factors going into that. And the bottom line is it does not matter what people tell you. It doesn't matter if you shut off at 75, 85, 95, 100, 120, whatever. Maximum amount, minimum amount. None of that has any bearing on how you did. You are taking a different test than everybody else. You are. And it's going to feel like you're getting them wrong.
Right, yeah.
So don't try to afterwards. Just take a deep breath. Wait the couple days you got to wait. Enjoy yourself and wait for the results. And use us if you need additional help. That's what our prep program's for.
Yeah.
But I'm telling you, no one walks out of that test feeling great. If they do, they're lying to you. And no one can determine based on the amount they got wrong that they did better or worse. Yeah. It's just not true.
The other thing I'll say too is with COVID, they started doing the testing from home, where you can test from home. If you're taking the test from home, it's always 110 questions.
Yeah.
That's one thing. People are like, oh, I got 110 questions. Do you take it from home? Yeah. Okay. Well, that's normal. So everybody, if you're taking it from home, if you're not taking it at a center, everybody gets 100 as of right now.
Yeah.
As of the recording of this podcast.
Yes.
So, all right, cool. All right, 2 more questions.
All right. I'm starting EMT, and my professor seems to be putting the fear of God, quote unquote, in us. This comes from Candace. She says, he tells a lot of war stories and acts like someone's going to shoot themselves in the face right in front of us in the field. Is it that bad, and how do you prepare for something like that?
Okay, so
a couple things to unpack here.
Yeah, right.
One, education.
Right, yeah.
How this person's educating you.
So here's the thing, is that there unfortunately is a theme, and hopefully we're moving away from it, but there's this theme in especially EMS education where a lot of the professors, I don't know if I should call them professors, a lot of the teachers, instructors are veteran medics or whatever they are, and they kind of got into education because they just want to tell people about how great they were. I mean, like
that's anywhere. It's
anywhere.
It's anywhere. It's
But
anywhere.
I think we're getting away from it a lot. I think we're moving towards them more. But unfortunately, like I said, I don't think I think sharing personal experiences is a good way to help educate. When your entire curriculum is based off of just telling your war stories,
you're a bad teacher. You're just a bad teacher.
Yeah. So I apologize, Candace, that is occurring to you. Are you going to see traumatic things in EMS? Yeah, absolutely. Is it going to be every day? No. I mean, I think the majority of what we see is pretty normal, and just like with
when
any
it becomes normal,
emergency medicine job,
that's one thing. Yeah, that kind of stuff becomes normal. First of all, no medic is seeing someone blow their brains out every day in front of you or anything like that. Like,
well, you say that, and because you said that, we'll now get 7 emails from people to be like, "I've had
every
5
day.
people shoot themselves."
Well, no, I have.
This is how people are.
I have had people commit suicide in front of me. Like, it has happened, and we've tried. And yes, it is traumatic, but you learn how to cope with those things. You build a support system within this. And it's really important to remember that, and mental health is a super, super important part. And we might do a podcast just on mental health sometime soon. But like research with PTSD in medics and EMTs and things like that, like that's all real. But understand something too, like PTSD is a curable condition. I believe you and I have had PTSD and talked to people and gotten through that, and that's fine. Like it's not something that just haunts you the rest of your life. Like it's a curable, treatable condition. That's a normal process to go through. You see something upsetting, it upsets you, you talk it out, you get that quote unquote treatment, and then you're good to go. It doesn't make you crazy. It doesn't mean you have a psych issue. That's a normal way to adapt to seeing a traumatic event, right? And then you don't have nightmares 7 years later. It goes away because you were able to talk through it. So
and
recognizing
that being said, for some people who have seen horrible things,
it might be something
they struggle with it for a long
yeah.
time, and they may. But again, I think that like what you're trying to attest to here is that like there are ways to deal and cope. It's not like all of a sudden you just like now you're thrown to the wolves.
You're just ruined.
That's it.
Yeah, there's always help. And that's why I think it's important to try to start in this field as best you can with a support system. That support system doesn't have to understand what the job's like. They just have to be supportive of you.
Right.
You know what I mean? And that's why I think we're very blessed with our families and with each other that like we can talk through those sort of things. But no, I don't think that this is a field that you should be scared of. I don't think it's a field that's going to change you in negative ways. As long as you keep your head up. I think that it's going to change you in positive ways. I think it's one of the best fields to be in. I think you can make a huge difference. And if your professor is always telling war stories, scary, spooky war stories, I would probably contest that he probably hasn't seen that much, to be honest with you. Right. But because it tends to be the people that see stuff tend to be the quietest.
Or just doesn't know how to teach the lesson plan in front of him, so he's just using stories.
We use personal experiences in order to connect people to education. Beyond that, they're used to stroke your own ego. Right. And there might be some of both going on with that. And I'm as guilty of it as anyone as an instructor. Sometimes I'm like, oh, you got to hear about this call. It was so cool, But no, I don't think that this is something to be nervous about. I think this is something that you should be excited for.
Well, another thing is that the most traumatic things I've seen are always in like the clinical setting. So like I'll watch a movie with some like really gruesome thing, and that will bother me more sometimes than when I see something extremely traumatic, but I'm in the emergency department in my element. Like it becomes very clinical. I mean, like you kind of separate from that a little bit, and it's not in an unhealthy way. It's just like you
learn to have a shield up, I think,
right?
Because you're prepared for those sort of things, and that's
like if I was walking down
okay.
the street and someone like got like their leg chopped off and was bleeding on the sidewalk, like that would be like way more traumatic than when someone comes in with their leg chopped off bleeding But I'm there. That's what I'm there for, and that's the point, So
I just think that when it comes to this stuff, the biggest help is just understanding that it happens to all. Like if something's happening to you, it has happened to somebody else too. Yeah. It happens to all of us. Part of this whole stigma and the issue with like mental health and EMS and the fire service and the medical field is just that we don't really talk about it as much. I think in hospital does a little bit better than we do, but like sometimes that like type A personality, tough guy type mentality, like if you have I'm telling you right now, if you have a bad call, or maybe a call that doesn't seem that bad to you, but for some reason it's
triggers
and you have a
something for
nightmare
you
from
or bothers
it,
you.
I've had nightmares about calls.
Yeah.
Like, talk to somebody about it. You don't even have to talk to a professional. Talk to your wife about it. Talk to me about it. Send an email. Hey, this bugged me.
Yeah.
Okay, yeah. Like, it just helps to talk it out and understand that those things are just normal. Those are normal responses to seeing traumatic things.
Yeah.
It doesn't have to be like, oh my gosh, I'm having nightmares. I must have major PTSD and now I'm in all kinds of trouble and I have a psych disorder or issue. Like, that's just not what's happening. Normal stuff. Right.
Yeah.
So, but yeah, I would not worry about every day someone shooting themselves in front of you. If that's going on, maybe you're having.
I say if someone's shooting themselves in the face every time you're around, it might be you.
It might be a you problem.
You problem.
So, but yeah, no, I think you should be excited about this field. And I don't think if that's what is making you nervous about it, guess what? We were all nervous about that when we were starting, and it's going to work out okay. You're going to have people to have you back. So
cool.
Last question of the day. This came from a surprise guest. Is there a good test prep program that I can check out to help me pass my NREMT?
Well, I'm so glad you asked.
This question is coming from maybe you.
I'm so glad you asked. So this will be our plug. Our National Registry Prep program, we launched about less than a year ago. Almost a year. Well, no.
Almost a year now. Coming up
almost a year now.
August something.
And we were nervous to put it out there because it was all fun to shoot and to put together and to build the curriculum, and then it actually had to be tested in the field. So we put it out there, and we have, and this is just exciting for us, but we've had a lot of success. I mean, and I'm not talking about like financially or I'm saying that like our students, when they take our prep program, we get emails saying, hey, thank you so much. I passed my exam on the first try. We have a 94% pass rate on this exam now, which is great. Yeah, I mean, I'm so glad that we were able to, kind of build this and put it out there. So if you're looking to study for the National Registry exam, whether it's EMT, advanced EMT, or paramedic.
Or you're just working through school, because a lot of people are using this as a supplement while they're getting lectures so that they can pass their program. The program's challenging enough, right?
Yeah. So check us out, sightsandsirens.com, our prep program. I said we're excited about it. We have a lot of fun doing it too, which makes the learning, I think, a little bit more. We also now have, like I said, we acquired Registry Ready, so we actually have some test banks now, and the paramedic test bank will be launching soon. So I'm excited about that. If you're an educator, we do offer kind of affiliate program. So if you have a bunch of students, like maybe you're not taking the exam, but you're an educator and you're like, hey, this could really benefit my students, please reach out to us. We do discount codes and packages for schools and things like that. Or if you know someone who's taking the exam, like I said, please push them our way. We'd really like to help you guys out.
It's a lot of fun, guys. We just have a blast.
Yeah.
A little bit about the program. We've got over 15 hours of video content. We've got like a 1,000-page workbook for you to work through and play around with while you're watching the videos, and then you can use that as a study tool. We do live lectures here and there where Chris or I will jump on and walk you through some more complicated concepts, things like that. You get access to Chris and I. You can literally like call my cell or text me, and we can talk, and I can talk you off the ledge if you're about to go in for the test, or I can get you distracted, and when you're done with it, like we can support you. If you have specific questions, you have access that way. And we've got questions within it. So every video's got at least 10 questions attached to it. You'll take a little quiz to kind of test your learning. Each video is only about 10 to 15 minutes. So they're easy, digestible little things. They're kind of a lot like this podcast. A little bit more vetted, but we're a little bit more on script for them. But yeah, and then we also have that Registry Ready test bank for you to kind of take gross amounts of questions to try to test your knowledge and improve yourself. So a lot of people have seen a lot of success for it. We hope that you can be one of those people. Check us out, sightsandsirens.com.
All right, guys. Well, thank you. We appreciate you taking the time to be with us. We will be back next week. And again, send your questions in. We'll be doing this Q&A thing periodically. So if you've got questions, please feel free to reach out. Don't hesitate to reach out. Training@sightsandsirens.com is where you can send those emails. We hope you guys have a good week, and we will see you next time.
Stay sweet. Hey guys, hope you enjoyed the episode. If you're an EMT or medic student, or an advanced EMT student, or an instructor of those students, we have a program just for you. With Sights and Sirens NREMT prep program, you get video lectures, over 15 hours of really vetted, great content to help you through your program and help you prepare for the test. Check it out at www.sightsandsirens.com.